think, yeah, thank you, Amar. It does dilate very well, quite well.
Thank you,
So
Abhay.
thank you, Amar, so very much. And I think we move on. We could spend whole day on Amar's innovation, but unfortunately, the time is an issue. So thank you, Amar, so very much. We move on to this challenging situation with Toric, and DR, please go ahead.
Thank you so much, Namrata, for inviting me over to this wonderful symposium. Shifting gears a little bit and challenging situations with toric intraocular lenses. Obviously, toric intraocular lenses have come to be accepted as a primary mode of correcting of cylinders in cataract surgery. This was a walk in the park case, at least that's what I thought. I had done a LRCS, and the patient required a toric intraocular lens implantation. Everything seemed to be under control, and as you could see, the phacoemulsification is a fairly soft cataract. The intraocular lens is slipping in. Please notice that there is no explosive release or sudden surge of the intraocular lens into the eye. But then it started tilting. I'm just showing it a second time just to show that there was not really any sudden jerk. But I was refusing to believe that there was a problem. So actually, I tried to position this lens, though it was getting tilted. And that just made matters worse. And that lens was literally falling into the vitreous. So essentially what I did was to hook the haptic. I did not want to lose the lens into the vitreous cavity. So rested it on the pupillary margin and the capsular rhexis. And the vitrectomy has not been done. You can see it dangling over there. Maybe not the absolutely the right thing to do, but at that point of time, I just went in and brought the lens up and wanted to just secure it. Just used a Sinskey hook. And essentially after this, I had to think. And as I'm doing this, as you can see over here, I've actually reversed the lens because in my hurry to save the lens, I've actually inverted the lens. And I was wondering whether I should just expand this lens and put a three-piece lens, non-toric, but then the lens was already inside. Doing a reverse pupil rhexis capture was not possible because there was no significant support for the haptics. So I went ahead and did conventional optic capture. So the first step is to go ahead and do an adequate anterior vitrectomy. And after removing some vitreous, I go ahead and use the diluted triamcinolone to make sure that the anterior chamber is fully bereft of the vitreous. And then subsequently, I have to rotate this lens. So fill in the anterior chamber with significant amount of dispersive viscoelastic so that I get enough space. Using two Sinskey hooks, I go ahead and rotate this lens. And then all along, I have one haptic outside the chamber so that this lens has less tendency to drop into the vitreous cavity. Now I'm trying to position the lens. Basically, the fairly thick haptics just go into the sulcus. Not really the ideal way to go, but I really did not have an option in this situation. And then you can see there's a lot of viscoelastic that has gone behind the lens. I go ahead with the aspiration cannula and remove that whenever there's vitreous strands that was presenting. I was exchanging with the vitrectomy cutter. With the irrigation flowing, now I'm just creating an optic capture. Mind you, these are planar lenses, there's no tilt, but then it's possible to do it. And the square edge optics, which can be rubbing on the back of the iris, are essentially secured in the capsular rhexis. You can see the toric markings over there. I have the Varion overlay, but right now you can see that. And it seems to be getting positioned quite accurately and at least on the table before even removing the irrigation cannula, I secure my side port and the main port and then go ahead and secure the last side port. And doesn't look great, but the intraocular lens seemed to be in position. And the patient was very keen on a complete correction. And this is something I left behind the patient with. I was always concerned about whether this is going to cause uveitis, glaucoma, etc. Kept the patient on steroids and NSAIDs for longer than what I usually do. But fortunately, as you can see, this 3 months post-op and the lens was quite stable and accurately in position. And as far as the visual outcomes at 3 months is concerned, the patient had a distance visual acuity uncorrected of 6.6, and of course, he needed a presbyopic correction. Going on to a second situation, this was a patient who had a post-hyperopic LASIK, and years back, not done in our center. This is, you can see both the eyes, that central hump over there. There was a great talk by Doug on how to handle these eyes. Basically, what we found in this patient, still there was a significant amount of residual eye stigmatism, high hyperopia. You can see that we have used the Barrett formula on the Barrett 2K TK formula. And this is actually a custom-made lens that we are using. And you can see the surgery, which itself is nothing very different. It is a fairly soft lens. And you can see the iridotomy over there, simply because it was a very shallow chamber. It had been done earlier. And this is essentially a phaco flip that's being done. And subsequently, we are going to implant the toric intraocular lens. Because it was a fairly thick lens, we had to enlarge the 2.4 millimeter incision to a 2.8 millimeter incision. This is actually a Indian-made lens, a customized lens, and you can see this lens being positioned. The Varion overlay is there, but it's not being shown up on the video. And this is what this is the result we got: a small astigmatic correction, but almost complete spherical correction. So obviously, even in these situations where a hyperopic LASIK has been done, you can go ahead and employ these lenses to essentially debulk the astigmatism, but not correct them completely. And the conventional teaching has been there: whenever you have irregular cornea, you don't use toric intraocular lenses. Essentially, it has to be an orthogonal regular cornea. But you have situations like this, for example, not only for toric ICLs, but also for toric intraocular lenses. You can see a keratoconus patient, because of the age, it had been quite stable, coming in for cataract surgery. So essentially, in these situations, what we do is to do a topo-guided PRK so as to regularize the cornea. And you can see this has become a fairly good with the rule astigmatism with the shape of the bow tie. And this was what was pre-op. This is essentially the ablation pattern where we took care of the area of steepening, and peripheral to the area of flat area, we did some laser, so that this is the ablation profile. And this is the picture that we landed at. A more controlled astigmatism, which obviously is amenable to a correction with a toric intraocular lens. Another situation like this, these are essentially the best corrected visual acuity is 624, because there is significant amount of cataract. So you see, once again, we have been able to do a topo-guided PRK prior to cataract surgery, so that we are able to make an irregular cornea into more regular astigmatism, which can be subsequently dealt with a toric intraocular lens, which is essentially the same as what we're all used to. Thank you so much for your kind attention.
Thank you very much, Dr.